Hi there, I'm Cherise. I'm a nurse practitioner. I've been a nurse practitioner since 1999, believe it or not. My husband is Steve Branch. He owns Central Drug and they're sponsoring this webinar today. He is a functional medicine pharmacist. I'm a nurse practitioner with 20 plus years, as mentioned, in 20 plus years of experience in internal medicine, and have been practicing functional medicine with a particular interest in gut health, autoimmune disease, and hormones over the last 5 to 6 years. And it's really been a blessing to me. I've gotten to meet some wonderful patients and help them feel better and live more productive lives. So today I'm going to start sharing the screen here. There we go. We're going to talk about bioidentical hormone replacement therapy 101, and I will try to make this fairly quick so we have plenty of time for questions. So what are our goals today? We're going to look at a female's basic life stages. We're going to present basic knowledge about BHRT, and we're going to review categories of bioidentical hormones, or just our sex hormones in general. So most of you have seen this slide before. This has to do with what's going on hormonally during our menstrual cycle. And I'll talk about the different phases of our life cycle as a female, premenstrual, and then perimenopausal and menopausal after this slide. So what happens on day 0, if you look at the bottom left-hand portion of the screen, that is the first day, day 1 of our cycle per se, is when we begin to bleed with our period. For some ladies, that's 3 days. For some ladies, that's 7 days. When things start getting cattywampus before menopause, those years termed perimenopausal, we can bleed long for 12 days or 8 days. We have dysfunctional bleeding. But for the sake of having a perfect menstrual cycle, let's say this person right here, they're bleeding day 1 to about day 5. So you can see some of the fluctuations in hormonal levels. Estrogen goes up, and then we ovulate around anywhere day 13 to 15-ish. And then estrogen level goes down, that's the yellow line. And then my favorite hormone and friend, progesterone, it's low in what you call the follicular phase of the cycle. After we ladies ovulate mid-cycle, there's a progesterone surge. This is called the luteal phase, as you can see. If sperm, the egg is not fertilized by sperm and the egg disintegrates, that's a sign that our body does not need that high level of progesterone to maintain the endometrial lining, which that's depicted down here. And then the progesterone level falls off, and boom, the whole thing starts over again. When that progesterone level drops, that's a sign for us to bleed and to shed that endometrial lining. And we do, okay? That's our next period. So basically that's our, in a very overly simplified fashion, our menstrual cycle that you've seen before. So we're going to talk about some life stages. So premenopause starts with when we're age 10, age 12, or some of us age 14, we have our first period. There's monthly fluctuations of hormones called luteinizing hormone and follicle stimulating hormone, and our estrogen and progesterones fluctuate as well. The most common problem that I see during this phase, and you've heard of this before, or you may have even suffered with it before, because most of our gals on this presentation were more in the perimenopausal and menopausal phase, but we'll quickly run over this. The most common problem here is PMS, premenstrual syndrome, and that's because our neurotransmitters, that's our brain chemicals, they're affected by fluctuating levels of hormones. There is a relationship between our hormones and our endorphins and our serotonin, our feel-good neurotransmitter of the brain. And we can often treat PMS with diet, exercise, stress reduction, and sometimes things like 5-HTP or St. John's wort. Here's a quick for humor. What should you say to your wife when she has PMS? That's right, nothing. That's my advice for you guys who are on this presentation, or for the ladies who will show this recording to their husbands. So another life stage, and I have many patients in this cycle, or this stage rather, called perimenopause. This is the period between the onset of our routine periods when we're rocking and rolling at 28, and things aren't rocking so smoothly and routinely. So it's this period between when we're younger and when we actually stop bleeding, which is termed menopause. The majority of my patients, this may happen as early as age 38. It may start happening around 44, 46. The periods become irregular. Sometimes they're scant and light. Sometimes they bleed very, very heavily. But this is the before menopause. Again, the average age to go into menopause in the United States of America is age 51, 52 on average. But again, for sure, at least 4 years before this, sometimes up to 10 years before this, I see in my practice abnormal cycles, heavy periods, because excessive hormone or lack of hormone, it varies from month to month. So you can often have a concept of what's called estrogen dominance. You remember how that hill of progesterone surged the second half of the cycle after ovulation in the luteal phase? When ladies become perimenopausal, they don't have as robust of a progesterone surge the second half of the cycle. So relatively speaking, their estrogen, even though both levels estrogen may be normal, progesterone may be low normal, but they are estrogen dominant, okay? And that can definitely cause some challenges for those ladies, such as I already mentioned, the excessive periods, excessive bleeding, irregular periods, heavy cycles, passage of clots, poor sleep. So that's more the perimenopausal stage. And again, more humor. I'm sorry I was a maniac this week, but now that I've got my period and I feel so much better, now you can hold me and tell me I'm pretty. But before then, leave me alone. So then we have menopause and we have postmenopause. So with menopause, obviously we don't have periods anymore. You are not considered officially menopausal until you have missed 12 consecutive cycles. You have not had any bleeding for a year. Some ladies just kind of stop bleeding. I have a number of patients that they might not have a period for 6 months, and then boom, lo and behold, here comes another period. If I have a lady who has not had a period for 11 months, and she decides to spot and have a cycle on month 12, she is not menopausal. She is still perimenopausal, okay? Again, postmenopause, once we become menopausal, are all of the years of our life after we've stopped having our period, whether we're on hormone replacement or not. So if you think about this, why are you taking time to watch this webinar and why am I taking time to give it? This is invaluable. We live to our 80s, to our 90s. We used to live until we were in our 50s, okay? So we didn't live, there wasn't much of our life to be left to live after we went into menopause. Now that is absolutely false. If the average American female goes into menopause at age 51 and she lives to 86, do the math. That's 35 years that she will be postmenopausal. So we want to be making sure to be aware, what can we do to keep ourselves healthy during this phase? What can we do to protect our heart, our cholesterol profile, our bone mass, because we've got 36, 35 years to live with ourselves yet, right? So anyone with these, I bet you I hear ladies talk to me about these things a lot. Some of these are a surprise to you. Some of them are not a surprise to you. The most common that we think of with menopause, we think of symptoms like hot flashes, sweating, maybe dry skin. We don't necessarily tie it to hair loss or hair thinning or gassiness, flatulence, or sore breast. We start to snore. Maybe our mood, we have mood fluctuations. There's some depression. I hear often a lot, loss of sexual interest. And I also hear frequently, I've got this hair on my chin that I never used to have before. Varicose veins, migraine headaches, memory lapses, bloating, and worst of all, and obviously weight gain, I'll put that right there at the top of the list. The average female, whether she goes into menopause after she has had a complete hysterectomy at age 40, or if she has just stopped bleeding on her own at age 51. I see challenges with weight gain, and the average female will gain about 30 pounds after she goes into menopause. This is due to high levels of the wrong hormones and losing the right hormones to keep things balanced. For example, if our estrogen level goes down, and our progesterone level is down, but our testosterone and DHEA levels are still normal, I didn't say high, but normal, we tend to gain fat around the middle. If the ratio of our estrogen or estradiol to progesterone is too high, we gain weight more around our hips and in our rear end. But the worst part of menopause is this. We females start to look more like our male partners. And unfortunately for them, if they're not protecting their testosterone, eating right, and getting some exercise in, they start to look more like us. So that's kind of a sad picture right there, but that is the truth. So let's talk about, we just briefly covered the different stages. Let's talk about synthetic versus natural hormone replacement. So what is synthetic? Synthetic means artificial or patented pharmaceuticals. They're generally not found in nature, or at least not in humans. The chemical structure is different from our sex hormones that we had when, I like to say, we were rocking and rolling at age 28 or 32. Synthetic hormone replacement, for example, Premarin, it is not identical in structure or activity to our natural hormones that we're now trying to replace. An estimated about 50% of all women quit taking synthetic hormone replacement within the first year after they're started on it because they don't do well with the side effects. And that makes sense, right? Because chemically, synthetic hormone replacement, that hormone replacement does not match the chemical structure of our own hormones. And synthetic hormones waste energy because they give incomplete messages to our cells. And then that fails to produce a balanced hormonal response. So why is there not more people talking about bioidentical hormones? Because a substance found in nature cannot be patented. And in other words, there's no money to be made from it. Synthetic hormone replacement, obviously that's big pharma, and there's plenty of money to be made from it. But really, to illustrate that, if you see the three hormones, there's to just not to confuse the issue, there's more than one type of estrogen. There's estrone, estradiol, and estriol. You can see their chemical structure here on the top of this slide. And you can see with synthetic hormone replacement in the shaded gray area that that chemical structure does not match. It really doesn't even come close to matching the chemical structure of any of these three estrogens that are found naturally within our body. This one, equiline or equilin, that is Premarin. Okay, so you can make an argument. Premarin comes from horse urine, horse TT, right? That's about as natural as it can get. However, it still doesn't match the chemical structure of our God-given hormones. And again, how many of those unwanted side effects listed in the drug insert on pharmaceutical synthetic hormone replacement are caused by the change, just the change and the difference in these structures from the natural hormone molecule. Again, you don't get a balanced response. So what is natural? Again, natural means it's not man-made. It's found in nature. Look at the Premarin example. Premarin is natural. Horse urine is found in nature, but as a manufacturer may promote it as natural, it's natural, but it's definitely not bioidentical. It does not match the chemical structure of the hormones that we were born with. So bioidentical and plant-derived hormones. Bioidentical means hormones that are molecularly identical to those that we already had. the same chemical structure. Bioidentical hormones are plant-derived. They are chemically processed. They're like, for example, progesterone. It is made from Mexican yams and or soy plants. So yes, there is a processing that takes place, right? But the precursor is found in nature. And here's another picture of some chemical structures to illustrate that. You see human progesterone in the middle. You see bioidentical progesterone made from those Mexican yams on the left, made in the lab. And then you see Provera, which is a pharmaceutical prescription. That's our prescription, Progestin, Progestin. That is different, okay? So here's a horse. You want to give me what? I don't think so. So horse isn't going to be using human estrogen, and we don't really want horse urine or Premarin either. What really is natural? Again, this is another slide to illustrate that you've got human estrogen. We've got about 20% estradiol, maybe 10 to 20% estrone, 60 to 80% of estriol. Whereas Premarin, see the mix, it's entirely different. It's a big spread of what estradiol can be contained in there. Estrone is thought to be the bad player of estrogens. And look how much estrone is contained in Premarin. And then equilin, 6 to 15%. So overall estrogenic activity, this estradiol is 12 times more potent than estrone. So estradiol is our workhorse, and estradiol is also about 80 times more potent than estriol. And on breast tissue proliferation, so when we're thinking about protecting ladies from breast cancer, estradiol is estimated to be about 1,000 times more potent than estriol. There's different receptors in breast tissue. Estrone, this middle guy, is thought to be the estrogen, once again, most implicated in hormonal cancers. So estradiol is our workhorse, right? It needs to be dosed carefully and individually, okay? We don't all need a bucket of estrogen or estradiol. Estrone, I don't utilize it at all in my practice because we do think that, or we do feel it is the bad player. Estriol, the guy on the bottom there, much weaker. It does have a higher affinity to those receptors in breast tissue, and it is thought to be breast protective. Okay, so remember that of the 3 kinds of estrogen. This is just a book that I always put here. It's a nice read for those of us who are perimenopausal or menopausal, so you'll have it on your slides. So, bioidentical hormones. What do those all include? I already mentioned estrone. I don't utilize that in my practice. The workhorse estrogen, estradiol. The weak friendly estrogen, estriol, progesterone, testosterone. We're not going to talk much about DHEA or pregnenolone or androstenedione. Okay, just remember that estrogens tell the cells to go full speed ahead. In particular, most importantly, our breast and our endometrial lining of our uterus. You want to be careful about that. But estrogen has over 400 crucial functions in our body. Slows bone loss. It doesn't help in forming new bone. I know that sounds different than what you've heard, but it maintains bone. It's critical to maintain our bone health and our bone mass. So again, what are the functions of estrogen? Well, as you can imagine, there's over 400 functions. I can't put them all on these slides because it's overwhelming enough. But estrogen, when dosed and introduced at the correct time for a postmenopausal or a menopausal female, can prevent Alzheimer's disease, increase our metabolic rate, make us more sensitive to insulin, again, maintain our muscle and bone and decrease tooth loss. It is eye protective. It reduces our risk of macular degeneration and forming cataracts. It helps our good cholesterol. And then the fun stuff, we know it helps maintain our collagen in our skin and our skin elasticity. Other functions, remember there's 400. It can help with sexual interest, decrease blood pressure. Obviously, it can protect us cognitively, improving our mood, our energy, and help us with concentration. Estrogen Even the pharmaceutical types such as Premarin have been found to reduce our risk of colon cancer. Just remember, transdermal estrogen replacement can also help in the formation of neurotransmitters in our brain like serotonin, which can decrease depression, anxiety, and pain sensitivity. So all these functions of estrogens can be overwhelming, but simply put, our body has receptor sites for estrogen everywhere, not just in our uterus, ovaries, and breasts, but our brain, our muscles, obviously our bone, colon, eyes, heart, lungs. So ladies who smoke have lower levels of estrogen. They generally don't do as well going through the perimenopausal and menopausal phases. Just know that hot flashes can be due to fluctuating levels of estrogen rather than just a true decrease, okay? So these three types of natural estrogens, I always tell patients, again, it can simply be them fluctuating that causes difficulty. 50% of all hot flashes and night sweats in my practice, and this is a known fact, are caused from something other than fluctuating estrogen levels. You talk about stress, you talk about drinking some alcohol at night, or simple carbohydrates or sugar at nighttime before we go to bed. Those can all contribute to hot flashing and sweating. So eating a diet high in fat, low in veggies can also increase our liver recirculating estrogens, and that also can predispose gals to breast cancer. Researchers have concluded that when we replace estrogen transdermally, within 5 to 7 years of menopause, that last period, we could decrease the risk of heart disease by almost 50%. But again, the timing and the administration and the dosing, the timing of when we introduce estrogen, the dose amount, and how we give it all plays into that. So estrogens given by mouth. I'm not a fan of estrogens given by mouth for menopause, okay? Really not really much of a fan for them given by mouth for birth control. And that's another story and another talk. But when we take estrogen by mouth, an estradiol pill, when we take it by mouth rather than transdermally, we actually can see a blood pressure increase, increased triglycerides, we knew that one, gallstone formation, elevation of liver enzymes, decreased growth hormone, it makes it harder for us to keep our weight off, and increased sex hormone binding globulin, which in turn reduces the amount of testosterone that we have available to use. Also estrogen, and this is an important one for all of us gals, when we take it by mouth, it can actually increase carb cravings and increase weight gain, as I mentioned. So more humor. I need some estrogen. Any questions? So what about this guy named progesterone? You heard Cherise say it's her favorite hormone. So the progesterone is our balancing hormone. It tells cells, whoa, slow down. It counteracts the influence of estrogen to cause excessive growth and proliferation, in particular in our uterine lining and our breast cells. It tells the cells, it's kind of like a stop check, right? It kind of tells the cells to do something other than keep proliferating. It's a check and balance on estrogen. It also is a bone trophic hormone, and in conjunction with estrogen, it obviously will increase bone mass. And so those of you who are osteopenic or osteoporosis, this is an especially important talk for you. Can also raise HDL, our good vacuum cleaner cholesterol. And remember, progesterone, just like estrogen, has receptor sites in almost every cell of our body, not just the uterus. So I do give ladies who have had a hysterectomy but still have their ovaries intact, or even if they do or don't, ladies who have had a hysterectomy, their uterus is gone. I still not only replace their estrogen if their testing warrants it, but I replace their progesterone, because progesterone can be helpful with myelination of nerve fibers. It helps with it helps with how we perceive pain. It can also help in fibromyalgia, and it can help with sleep and mood. So This synthetic form of progesterone, we know it better as progestin, okay? Yes, this is the progestin that we give our 18-year-olds in birth control pills. And when you read the side effects, you may think twice about that. Progestin can cause weight gain and appetite increase, fluid retention, decreased energy, mood swings, make our breasts tender, acne, can thin our hair, and it does lousy things to our cholesterol. It increases our bad LDL and decreases our good HDL. It also increases our risk of breast cancer. That is a known fact. In fact, let me go back to that slide one more time. Taking oral progestin after the age of 40. So if you are on birth control pills for your periods and fluctuations after the age of 40, that progestin can actually increase your risk of breast cancer, okay? So the famous study was a Women's Health Initiative. It was a government-sponsored study that began in the late 1990s, and it was stopped in 2002, 3 years early. I was already practicing in internal medicine at that time. So you can imagine I had a lot of older ladies, or what I like to say, like fine wine, wiser ladies who were on hormone replacement. We called them all into the office and we took them all off of their hormones. But let's talk a little bit about what this study showed. It showed a 41% higher stroke rate in ladies taking PremPro, doubled the rate of blood clots, an increase in breast cancer of 26%, an increase in heart disease. Notably, and in all fairness, they did show colorectal cancer, as I mentioned earlier, to be decreased. And obviously, these ladies' bones were stronger on PremPro and they had a decreased fracture risk, big time decreased fracture risk. So when we stopped the study, or the researchers stopped the study in 2022, they continued watching the ladies, they continued the study on ladies taking Premarin, the horse estrogen only, not PremPro. And what did they found? They found in the following years, when they reanalyzed that trial's data, it actually showed in the ladies on Premarin only a 23% reduction in breast cancer compared to the ladies on placebo, or the sugar pill of the study. You know, we generally give a sugar pill to compare our results. Again, the reanalysis of that data also showed that the use of hormone replacement in younger women, or early post-menopause, early on in their menopausal phase, 5 to 7 years, actually had a beneficial effect on the cardiovascular system and a reduced incidence. And please, if there's anything that's your take-home message, because heart disease is rampant in women, it's not just a disease of men. But there was a significant reduction in coronary artery disease and all-cause mortality in my younger postmenopausal ladies who were started on estrogen early within menopause. So the public perception of hormone replacement, and we have not done a good job as providers, it's still out there thinking that hormone replacement is this bad thing and there's negative consequences. So the public opinion, and again, providers don't help with this, is still negative. And so we have so many ladies missing out. Not everyone's appropriate for hormone replacement, but many, many, many are. And we have those ladies missing out on important benefits, such as reduced instance of cardiovascular disease. And then there's obvious quality of life, right? So again, look at the sentence in bold down there. Negative consequences has come of us taking everybody off of hormones back in 2003 when that study result was announced. I added this slide early this morning. This is why the research and the science has not caught up to the message that we providers have given to the public. The North American Menopausal Society, their 2017, notice I'm not saying 2021, but 4 years ago, their position statement was, you can read this on your own afterwards, women younger than 60 Women within 10 years of menopause onset, and those, and this is important, no contraindications. Some ladies do have contraindications, but most don't. The benefit risk ratio is most favorable for treatment of bothersome vasomotor symptoms, that's what VMS stands for, and those at elevated risk of bone loss or fracture. Ladies who start hormone replacement more than 10 to 20 years later, who are age 60 or older, then we're not so sure. Then we really need to talk to those gals. Have I started ladies older than 60 on hormone replacement? Yes, but not without a long conversation. Benefit versus risk. What is their family history of heart disease? What is their family history of colon cancer? What is their history of breast and prostate cancer? You have to look at the individual. That's what it comes down to. But the moral of the story is everyone needs to look at, and I'm talking to providers now, the North American Menopausal Society, their statement. This is just a nice book on natural progesterone. This is our answer here. Progestin was the bad player in the Women's Health Initiative study, not natural progesterone, okay? So what are the functions of, I'm gonna check my time, of testosterone? So we know a lot of these: enhances our sex drive, has to be balanced with estrogen and progesterone, enhances our well-being, self-confidence, and motivation, improves our energy level, bone building, muscle mass and strength, can help combat excess body fat, and elevate norepinephrine in the brain, which has the same effect of taking a tricyclic antidepressant. We need estrogen and progesterone to be balanced. It is critical because I see patients every day come to me that have been placed on a high dose of testosterone or a high dose testosterone pellet. Do know that if given alone, testosterone can actually increase your risk of heart disease. Synthetic testosterone in a pill called Estratest, which has estrogen and testosterone taken by mouth, has actually been linked to cancer of the liver. So beware. Causes of lower testosterone: menopause, childbirth, stress, chemotherapy, stress, and stress, and more stress, depression, post-traumatic stress disorder, birth control pills results in lower circulating testosterone free to be used. And actually our statins can lower testosterone. DHEA, we're not going to go into that much. I measure levels of DHEA as well. DHEA is the precursor to our estrogen, progesterone, and testosterone. It does have anti-aging effects, increased energy, and it helps decrease body fat. It does support our immune system when we think of how to protect against COVID. It does promote weight loss. And this is the steroidogenic pathway. You can see cholesterol's at the top. Here we go down to our androgens. From cholesterol, we go down to progesterone. And then we also go over here to estrogens. So I just wanted to let you know that too low of cholesterol is not necessarily a good thing. We have to have cholesterol to make our sex hormones. Females should also note that yes, we share androgens with males. Males, when they're rocking and rolling at age 28, make 7 to 10 milligrams of testosterone every day. Females make about 1/3 of 1 milligram a day, even when we're rocking and rolling at age 24, age 28, age 32. So high dose testosterone is not the answer. The key to bioidentical hormone replacement is individuality at physiological doses, not supraphysiologic doses. So here's this gal. Of course, doc, of course, nurse practitioner, I want a second opinion. Is your wife around? Because Lord knows she'll know how I'm feeling. Xenoestrogens, I'm not going to talk about much of those, even though they're very relevant. We are exposed tremendously every day, the second we get out of bed, to xenoestrogens that disrupt our sex hormone receptors. They disrupt the normal function of our hormones, things like our fancy smelling lotions, skincare, shampoos, pesticides, a lot of environmental toxins, microwaving your lunch in Tupperware, drinking water out of a plastic bottle. That is a no-no because they disrupt our hormonal balance. Xenoestrogens can also be stored in our fat cells and they are non-biodegradable, you can guess that's an extra cancer risk as well. So it may be very difficult to obtain hormonal balance and relief of our symptoms if we don't look critically at lifestyle changes. So 5 reasons to consider BHRT. Obviously, symptom relief, prevention of memory loss when timed appropriately, when BHRT is timed and dosed appropriately, heart health, bone production, growth and repair of our tissues. Those are definite reasons to consider hormone replacement and bioidentical hormone replacement. There are other therapies to help us with our symptoms, like obviously good food. It always starts with good food, movement, again, getting rid of plastic in our life, nutritional supplementation because our food is not as nutrient dense as it once was. And for some, perhaps some pharmaceutical agents, or again, bioidentical hormone replacement. Do know that every conversation in my office starts, and in the pharmacy, starts with lifestyle change. What are you eating? What are you drinking? We cannot escape that. So summary, what, why, and how do we do BHRT? Natural not only refers to plant-derived, but it refers to the chemical structure matching exactly what we had when we were rocking and rolling at age 28. Hormones have many important benefits. Bioidentical hormone replacement has tremendous advantages compared to synthetic therapy. It doesn't harm you, for one. Number 2, the dosing can be quite tweakable and individualized. But do know this, proper bioidentical hormone replacement, it does require substantial effort and time, both on the provider's part and the patient's part, because there are many factors that affect symptoms related to our hormone levels being imbalanced or our hormone levels decreasing. It is always better to start with a low dose and closely monitor the results. Again, some of my two most challenging patients are these patients. The patient who is perimenopausal and her hormone levels have not bottomed out and are not constant yet. She's in that fluctuation stage between age 40-ish and 50-ish. I describe to these patients, they're like my parents used to make me mow the lawn with a push mower. And when you would go over an uneven surface, a lot of times it was punishment, but we'll talk to mom and dad about that later. But if you're utilizing a self-propelled push mower and your gas level in the tank gets low, and then you're mowing over an uneven surface, you're looking at the mower going, that's perimenopause. Those ladies are hard to treat. One day their estrogen level is high, the next it's low, and so on and so forth, along with progesterone and testosterone. But mainly the estrogen is the biggest culprit. So that is my first hardest person to take care of and to make them feel better. But the person that is even more challenging is someone who has come to me who has been significantly overdosed with hormones, too much estrogen, too much testosterone. It takes a good 6 months, even a year, to get those ladies back in balance, and they don't necessarily feel good. We do a lot of supportive treatment therapy. We're here for a shoulder for them to lean on, but that is a challenging patient as well. So be forewarned, buckets of hormones are dangerous and they are not the answer. In our practice at the pharmacy, we measure hormones by saliva. This is an example of 2 kits that we use. The saliva test kit you see on the upper left measures estradiol, testosterone, progesterone, DHEA, and you can also measure our stress hormone called cortisol. I feel saliva because it measures tissue levels of hormones, the hormones that are able to be used. It is my gold standard for keeping my patients at the lowest possible dose that provides them the most benefits and makes them feel the best. It allows me to dose in physiological dosing strengths. Saliva, in terms of measuring cortisol, our stress hormone, which comes from the adrenal glands, saliva is already considered gold standard, even in conventional or allopathic medicine, to measure cortisol. No secret there. So that's that test kit you see on the bottom right, the adrenal stress kit. Many of my ladies, they need small changes with their sex hormones, but they need big changes when it comes to their cortisol levels and their stress levels. This is teeny tiny, and for that I apologize. This is an example of how a test result, a saliva test result, looks when I am measuring estradiol, progesterone, testosterone, and cortisol, and the graph. I do find this test result quite comical because, as you can see, cortisol, God designed it to be highest in the morning. That makes sense. The highest when we get up and we're facing our day, out the door we go. Lowest in the evening. Okay, time to settle down and go to bed. I can name one patient in my practice over the last 5 years that their cortisol measured fairly close to this. Stress and sugar are huge culprits that we all face these days. And stress, obviously, external stressors, internal stressors disrupt our cortisol pattern. And many times I see that highest level of cortisol at night. Well, of course that gal's not going to sleep easily. We've got to do some things to lifestyle management and some adaptogenic herbs, perhaps progesterone at night, to get her cortisol level settled down so she can get some quality sleep. But I mainly wanted to let you guys see that's what a sample test report looks like and share that with you. So today's truth is this: there is no magic hormone or combination thereof that can indiscriminately be used for all of our females. Everyone is individual. Hormonal balance for that individual must be the ultimate goal for all women. That's just the way it needs to be. In other words, individualized dosing, not super physiological dosing. You have to measure, ladies. You have to introduce hormones at the appropriate time by the appropriate route, and you always start low and you go slow. That is our mantra at the pharmacy as well as in my practice. So those are nice words by Dr. Collins there. So questions, forgive me because this is not a beautiful looking slide. Give Central Drug a call, that's their main number. Reach out, you can send me your questions in the chat box. And I'm happy to take questions now. Thank you so much. Because we have a large number of folks in this webinar, I'm not going to unmute you. I'm just going to take the questions out of the chat box. And the first question is, how long does it usually take somebody to feel better when they are having horrible hot flashes? Well, that's a great question. And I'm going to answer it. My weenie answer is this: it depends on what those hot flashes are from and what we discover them to be from. So I would ask that patient, when's the last time you had lab work? Let's say that patient comes to me and they're on thyroid medicine. Maybe we need to check their thyroid. Are they overdosed? Are they underdosed? Too much thyroid? Are they drinking caffeinated beverages at night? Are they having 2 glasses of wine at every night? That can definitely cause hot flashes. Do they have a college age student that is having challenges navigating the college world, and they have worry for their kiddos? Their husband is less than supportive. They're going through a divorce. That can all lead to hot flashes, separate and distinct, because they affect cortisol, which in turn, there's cortisol interacts with the sex hormones, interacts with thyroid, interacts with vitamin D3, which is a pre-hormone or a pro-hormone. So my complicated answer to that is I would measure the person's blood work. I would do a saliva test. The saliva test results take about 7 to 10 days to get back once they're sent in. Then after that, you start low and go slowly. The person it may be indicated by their test that they need a low dose of estrogen. So you conservatively replace estrogen. Perhaps they need, almost all of my patients over the age of 40 need progesterone replacement. Many of my ladies do not need any testosterone replacement. But the moral of the story is it takes about 4 weeks for progesterone to balance out, about 6 to 8 weeks for testosterone to balance out, and about 12 weeks or 3 months for estrogen to balance out. However, in the majority of patients, do you get them feeling much more quickly than that? Yes, you do. Yes, you do. Let me look for any other questions. Thank you. Am I taking new patients? Yes, we do see patients at the pharmacy, and the patients can have the saliva test done as a patient of Central Drug, or if they're not, they come in and they talk to the pharmacy staff. They can have their hormones measured with this kit. They don't have to be a patient of mine. Obviously, I am accepting new patients. I am actually accepting new patients for December right now. But yes, I love new patients, and just contact Central Drug. I wish I could type my phone number on that slide, and I can't, but I'm going to put it in the chat button here. My office number, 571-4173. So I'm sending that out to everyone. Thank you very much. We are complex individuals. We should be treated as such. All patients deserve conversation, and all patients deserve to be treated as an individual. Thank you guys for joining me today. Please send other questions. If you're like me, 30 minutes from now, as you're going about your Friday morning and you're going to say, wait a second, I don't know what she meant by that, or I have another question, please send those our way. We love questions, and we love being a resource for our community and helping our community become more healthy. Thanks a bunch, and you guys have a great weekend.